guys. My name is Harshel. I work at the Canberra Hospital as one of the intensive care specialists. I'm also a supervisor of training with the College of Intensive Care Medicine in Australia and New Zealand. I do not have any conflict of interest to share for this presentation. As Tapas mentioned, my interest always remains in quality in critical care and all the therapies we provide to our patients. And this has been a topic of my interest with bringing precision to most of the treatments what we can do. It's around 11:45 p.m. here, and my words might sound a bit rusty because it has been a long day. And I'm live right now. My daughter went to sleep just around half an hour ago, and she said, asked me why am I looking so smart before bed, and I couldn't answer her why I was trying to get up. But anyway, so in terms of renal replacement therapy in critical care, I think it is a cornerstone of the treatment for most of our patients now. And in past 2 decades, one would think that there has been significant amount of the research which has gone in to address some key questions in renal replacement therapy. We have identified different modalities by which we can provide some continuous renal replacement therapies. We have tried to answer the question of what dose is appropriate for our critically unwell patients. We have addressed which form of anticoagulation is better. And also, of late, in last probably 7 to 8 years, we've tried to understand the appropriate timing of initiation of renal replacement therapy. Based upon all of those research and some expert opinions, we've got multiple consensus guidelines. I think Tapas showed some of those guidelines at the beginning of this session. Also, I think individual hospitals and regions across the world have developed their own education policies, own practice policies. And we are not different at all. We also have our own continuous renal replacement therapy, which has been extensively used by doctors and nurses in the ICU. These policies usually get updated once every couple of years. The most latest update had been last year. And while we write all of those policies, does these policies help us guiding what should we do with our critically unwell patients? Perhaps yes, perhaps no. The reason I say no is largely because we have significant heterogeneity in terms of our critically unwell patients, what we look after. Our unit here in Canberra serves around 2,500 patients in a year, and we have mixed medical, surgical patients. We've got trauma patients, we've got cardiothoracic patients, we've got neurosurgical patients, and we've got long stayers in the ICU. So there are a lot of patients which have different etiology. They have got different severities of acute kidney injuries when they're present with, and they have got different physiological demands. At the same time, the treatment objectives, what we want to achieve from the renal replacement therapies, are also different for all of those patients. So when these guidelines are safe and can help you understand what is renal replacement therapy, they would never tell you what is best for your patient. And that's where a role of a diligent clinical intensive care specialists come into picture. The precision in the renal replacement therapy starts with thinking about what is the appropriate time to initiate your patient on renal replacement therapy. And in the literature, as I mentioned earlier, it's been quite well and extensively studied. I think in last decade, there's been 4 landmark studies. Most of those studies, they either defined early versus late. However, the definitions of early and late were quite different in some of those studies. There was one study which got published last year. It's called Akiki 2, which actually took a step further and said, how about we study late versus very late? I apologize for such a busy slide, but if you think about the trials, I would like to mention a few key important points of all of these 4 trials. The first one is the Akiki trial, which is mainly done in 31 French ICUs. More an open trial where we looked at early versus late initiation of renal replacement therapy. And when we said early, the patients who had stage 3 KDIGO acute kidney injury was randomized to receive acute kidney injury within 6 hours versus the late, where it was delayed up to more than 12 hours. And at the same time, patient had developed any further indications of acute kidney injury, such as hyperkalemia, severe metabolic acidosis, severe fluid overload, or significant oliguria to anuria. The trial didn't find any outcome difference in terms of the mortality, but an important finding was that more than 50% of the patients in the late group didn't require any renal replacement therapy. And a significantly important finding, although was probably mentioned in the secondary outcomes and was like higher incidences of catheter-related nosocomial infections in patients who started with the early renal replacement therapy, largely because there were more patients who were exposed to renal replacement therapy and had Vasquez insertion. Alien trial was an interesting trial. It was done as a single center trial in Germany. This was one of the trials which did suggest trend towards improved mortality in the early group. However, it's a small trial, had a low fragility index of around 3. And when we ruined the fine print, not all the treatments were standardized between the two groups. Moving forward, and one of the biggest study in this area was the START AKI. And this has probably answered the most important questions. It was multi-center randomized study involving around 3,000 patients in which patients, the trial has defined some inclusion criteria of patients who could go into START AKI. If those criteria were met, in the early group, the clinicians were asked to take a diligent decision and ask them to randomize these patients within 12 hours of meeting this inclusion criteria. While in the delayed phase or the late group, they were actually discouraged not to get onto renal replacement therapy unless they had some acute indication too. And again, those trials didn't find any significant difference in the mortality or rates of renal recovery. The last and the most important trial, I would say, was Akiki 2, which was published last week. So now, probably based upon the first two trials, the Akiki and the START AKI, we think that early versus late, there is not much of a difference. But when you think about late, how long can you wait before you put your patient under renal replacement therapy? And when you see this Akiki 2, where they compared late versus very late, the very late group, the patients were not started renal replacement therapy despite of reaching urea levels of around 50 or at the or when they had developed significant life-threatening complications. And when you look at the 60-day mortality, clearly like the late group had a trend towards reduced mortality as compared to very late group. So what do I take home from these 4 trials? I would say early versus late, there is not much different, but too late is definitely very too late, and probably one should not wait that long. So just based upon those trial results, do we think that we've got enough knowledge to implement or bring into our clinical practice? I would say no. The staging of acute kidney injury would not assist me to decide whether my patient should go on renal replacement therapy at this stage. However, there are a few other factors which needs to be considered. As we mentioned earlier, like 50% of the patients in the late group had spontaneous renal recovery. And if one could look at the meta-analysis which was published based upon all of those 4 trials, the mortality is actually lowest in the patients who never required any renal replacement therapy. So clearly, like there are other factors which are more important while deciding when to start your patients on renal replacement therapy. I'd like to share this slide, and I've taken it from at Keyworld and also Dr. Osterman's paper. And I like this slide to share as a concept to the group. When we think about other factors which might be more important, we always think about like what is the demand the patient's body is exposed to, and what is the capacity of the patient's native kidney to meet with these demands. How do I assess the demand? And the demand is predominantly determined by three major factors. The first is the patient's disease burden. How do I say that the patient has got increased or decreased disease burden? We always probably should look at the severity of their acute illnesses, but also we probably should try and quantify the chronic conditions and the severity of the chronic conditions they are bringing into this illness. For example, a patient, as mentioned in the earlier presentation, who has severe cardioabdominal renal syndrome would significantly bring a lot of disease burden from the chronic comorbidities as compared to a young, healthy patient who has developed a severe rhabdomyolysis post-crush injury, where the severity of the acute illness will be significantly higher. One could also think of the low solute load or the targets which you want to achieve from your renal replacement therapy, targets such as myoglobulin, such as urea, and sometimes like in patients with hyperacute liver injury, ammonia. Last but not the least is the patient's volume status and the fluid overload. So one has to consider some of those demands more in detail. And that should be weighed against the patient's own native kidney function. You may come across patients who's got advanced end-stage renal disease. You may come across patients who's got significant type 2 diabetes and has got chronic kidney disease from this and have reduced renal function. Some of those understanding needs to be considered when we expose our patients or when we offer renal replacement therapy to our patients. I'd like to consolidate some of those knowledge on this graph. Again, apologies for having these 4 graphs in one slide. These are the 4 different patient scenarios. And if I ask you to concentrate on the first graph, we are looking at a patient who has, again, like on the y-axis, we're looking at all the demands. And in the demands, if we look at the blue section is representative of the patient's chronic disease burden. The orange section in all of these graphs are representative of the chronic acute illnesses. And the green section represents the patient's solute and volume status. Now, in the first graph, if you think about it, a patient who's got reduced renal function, and clearly with the reduction in the renal function, the demand for the solute clearance and the fluid clearance is significantly going up. This patient is fortunate as his renal function is started to improve, and one can see that once the spontaneous renal recovery, the patient's kidneys itself are able to meet the demand, and patient had appropriate spontaneous renal recovery and hasn't required any dialysis. When one think about the second scenario, here, in which unfortunately the renal function has not improved, and there is continuous increase in the patient's demand, mainly in terms of the severity of the disease, but also in terms of the volume and the solute overload. The bottom 2 graphs looks at patients who got introduction of renal replacement therapy. The slide on the left, which suggests that this patient, similar to the slide on the top, if we have to initiate the renal replacement therapy, if you introduce an early renal replacement therapy, it might be able to meet their solute and fluid requirements, solute clearance and the fluid clearance requirement much earlier. And these patients may have earlier chance of recovery. However, if you look at the patient in the slide number 4 or the graph number 4, in which they have significantly high disease burden of the chronic disease, mainly represented by the blue section of the demand, those patients, as you can see on the day 2 and day 3, they have got marked increase in the demand. One would think that they could start a renal replacement therapy early and could get on top of their increased demand. However, because they've got significant limited capacity from the renal dysfunction, those patients are probably going to require medium to long-term renal replacement therapy in the form of IHT. And those patients probably might get transitioned to intermittent hemodialysis. Again, it is a conceptual model, and it does represent the need of understanding of patients' chronic medical issues, patients' chronic kidney disease, their status, and the reserve they have. Moving on to the next section about bringing precision in CRRT prescription. So in Canberra Hospital, we have developed this electronic medical record system on which we prescribe our CRRTs. So once we decide that this patient needs to go on dialysis, citrate anticoagulation is our default, and most of our patients usually have CVV-HDF as the default modality of the dialysis. As you can see, on the prescription itself, we have got some guidance for the medical staff. We write down that by default, you should probably put 150 mils per minute of blood flow, and the range could be this one. Replacement rate is by default is 200 mils. Similarly, dialysate, the default is around 1000 mils. The reason we do that is we have mixed medical bench in which our JMOs are either experienced to look after the patients on dialysis, can prescribe, or some of them have got very limited understanding of dialysis. So while these prescriptions are quite safe and can do some reasonable amount of the work, and patients can be initiated on those dialysis prescriptions, we have significant issues sometimes on patients who have got different needs which we want to achieve from the dialysis. So if you think about a fixed dose CRRT prescription, it's something similar to this, in which I've got patients of different sizes, patients have got different clinical conditions, they've got different physiological responses, and they've got different metabolic needs. And a one size suit is not going to fit all of them. However, they will be able to cover most of their important parts of the body. So what I like to bring onto table is what we say is a dynamic approach to your CRRT prescriptions. And when I say dynamic approach to your CRRT prescriptions, is about understanding your patient's daily goals, understanding their clinical progress, understanding their clinical trajectory, understanding their physiological responses, understanding their metabolic demands. And again, like trying to look for the signs of patients' renal recovery, and then modifying your prescriptions accordingly. So the first and the foremost thing is in terms of deciding what is the dose of the renal replacement therapy I should offer to my patients. And one of the most important and the landmark study, the renal study conducted by Australia and New Zealand Intensive Care Society, did suggest that higher doses of CRRT have shown not much improvement on the survival in patients with severe critical illness. However, we think that delivering a dose less than 20 mils per kg per hour is sometimes inefficient and does not meet patients' metabolic demands. An optimal dose, we think that is somewhere between 20 to 25 mils per kg per hour. However, in our routine practice, we usually prescribe somewhere between 25 to 30 mils per kg per hour, and that is mainly to allow the delivery deficits from frequent interruptions, sometimes from the circuit change, sometimes if the patients have to go for any of the CT scans or MRIs or transports to the theaters, that might take away some of their dialysis time on the dialysis and the dialysis dose for that day. The next part I'd like to talk about is precision in prescribing your dialysis dialysis order and targeting your solute clearance. So the prescription should always be adapted to your specific solutes. Consider about the target molecules. What is the target you want to achieve? Whether you want to clear someone's potassium, whether this patient has got higher burden of medium to large molecules which you like to clear, whether ammonia is your predominant target, you would like to have ammonia removed from your with the help of a dialysis machine, whether your dialysis is mainly to control the patient's acid-base disturbances, whether it is just for the fluid overload, or whether it is just for some small molecules such as urea. Largely, many a times we see that the patients are sometimes over-dialyzed. When I say they are over-dialyzed, the patients are sometimes continued on CRRT, and you see that the patient's urea and creatinine has normalized, or sometimes it's below the normal level marks at times. And that is a time I always worry about the loss of some of the important components in the dialysis. One would have always replaced phosphate and magnesium when they are on dialysis, but the other factors sometimes which he routinely miss are some of the nutrients, some of the water-soluble vitamins, and some of the medications. Moving on to the next component is the regional citrate anticoagulation. For us, the citrate anticoagulation is the first line and is default for all the CRRT prescriptions. In our experience, it has significantly prolonged the filter life. And it does help meet most of our quality indicators, what we like to follow in the CRRT. It decreases the downtimes by decreasing the frequent circuit changes. It has reduced our cost. One of my colleagues has done some cost benefit analysis in the pre and the post introduction of the citrate, and this has significantly reduced the cost. It also allows higher convective clearances at the lower blood flow rates. How do we bring precision in the citrate dose? Yes, a citrate dose needs to be again monitored based upon the patient's needs. We routinely monitor, as everyone would, patients' ionized calciums, the total calciums, and try and look for earliest signs of citrate toxicity and try and treat that as required. Now, seizing the CRRT, and this is something which is not well in many of the centers. Many of the centers, as I mentioned earlier, the patients once commenced on CRRT gets continued on the CRRT without much thought processes to say when to stop CRRT. This is a slide where I've used urine output to say trigger for discontinuation of CRRT, and those triggers have been taken from AKIKI and START AKI trials. A similar analogy sometimes we use, so for example, in patients whom we want to prone. When do we prone the patients? When we say that the PF ratios are less than 150 in patients who's got ARDS, you should prone the patients. Where do that trigger of 150, PF ratios of 150 come from? Most likely it is adapted from the PROSIVA trials. So very similarly, like we've introduced the concept of discontinuation of the renal replacement therapy. When you think that the patient is started to make urine output of like a liter in 24 hours, or probably 2 liters in 24 hours with the diuretic augmentation. Is that enough to think that this patient should be stopped dialysis if they meet just the urine output target? I would say perhaps not. You always think about the native renal solute clearance. If you think that the patient's urea and creatinine has started to drop down, the patient's fluid balance has improved, one could think that they should be stopping the CRRT. One of the factors we always consider in our center here is the availability of the intermittent hemodialysis. Many a times our patients, although are referred for intermittent hemodialysis, may not get hemodialysis for next 2 to 3 days. In those scenarios, we like to dialyze them to allow them to not have further dialysis sessions for next 2 to 3 days. Next, and last but not the least, is usually the patient's treatment goals. We sometimes do not have much insight into the patient's medical history and their treatment and the wishes. They've come to us as an extremist, and dialysis has been commenced as part of the multi-organ support. But once the patient's treatment goals and the wishes become more clear, there is always some consideration that patients should not be for intermittent hemodialysis, or patients should not be for further dialysis support. And those treatment limitations should always be discussed with the patients and their advanced care director. Next things to consider are how do we assess the quality in patients whom we are doing renal replacement therapy? Of late, till like last year, we didn't have a clear international consensus on what parameters we should be following. One of the parameters which we have started following in last 4 to 5 years is looking at our filter life. And we want to achieve at least 3 days of filter life from each patient who goes on the dialysis. Our citrate dialysis prescriptions and the citrate anticoagulation has helped us achieve some of those targets. When we look at the delivered dose, so although we write down on the prescription, we want to deliver around 25 to 30 mils per kg per hour or fluent dose as a dialysis dose, how much we are actually achieving on the dialysis machines. And many a times we will find that although you're writing down 30 mils per kg, you are actually achieving just 15 to 20 mils. And that is largely because of the time lost during the filter changes. Our aim is to have at least 80% achievement on the dialysis dose, which we have prescribed. We want to reduce our downtime on the CRRTs to less than 15% every day. And now the newer machines are actually able to tell us like how many times the machines have actually beeped. So we want to reduce the number of alarms on the machines, and we're trying to look at some of those alarms as one of our quality indicators. Last but not the least, when I say one size doesn't fit all, I wanted to just give a couple of clinical scenarios to make you understand what I mean by one size doesn't fit all. So on the left-hand side of the screen, I've got the patient's clinical scenario, and I apologize for the busyness on the slide. On the right side is the dialysis prescription. It's the default dialysis prescription, which our trainees can prescribe on our medical record systems. So it's a 69-year-old lady who's weighing around 70 kgs, came to the ICU with small bowel perforation and 4-quadrant peritonitis. She had history of type 2 diabetes with stage 3 chronic kidney disease with baseline creatinine of around 1.7 milligrams. And she's in severe septic shock with multi-organ failure on moderate doses of vasopressors. She's developed some acute on chronic kidney disease and has developed significant oliguria. She has got mixed metabolic and respiratory acidosis and has developed some hyperkalemia. She's currently been treated with some piperacillin, tazobactam, and fluconazole. She's come after hours, and one of our registrars has decided that the patient should get into the dialysis sooner rather than later, and has commenced on her dialysis, which is the default dialysis. In the course of like next 12 hours, the patient needed to have one circuit change and had to go down for a scan. So had lost around 1 hour on the dialysis, and achieved dose in that particular day was around 24 mils per kg per hour. On the day 2, when we assessed her, patient looked much better. Her vasopressor requirements were coming down. So this is the time when I say we need to bring precision into the therapy. When we look at this patient, do we think that the dose we have given is appropriate? Do we need to adjust any of the components of the dialysis dose? And when we look at that, yes, I think I would like to address some of those things. The hyperkalemia has improved. So I think the dialysis dose could be reduced in her scenario. Probably would like to reduce some of the citrate dose, considering that her citrate or the calcium levels were going up. At the same time, this is the time I would like to remove some extra fluid because she's received some significant fluids in the past 24 hours. So I'd like to adjust some of our dialysis-based dose and the treatment what we are offering based upon the clinical needs on the day 2. A second clinical scenario is very similar. This is one of our recent patients. He's a 54-year chap who's around 75 kilos, was transferred to us, again, I think around 11 o'clock in the night, after suffering a significant crushed injury under a container. When he was transferred, he was in severe shock with multi-organ failure and had developed what would look like was severe acute kidney injury, mainly from rhabdomyolysis. And understanding the severity of his acidosis and hyperkalemia, the patient was commenced on renal replacement therapy, again, based on our usual prescription. The usual prescription uses the Prisma OCal, which has around 20 millimoles of potassium in 5 liters bag. So this patient was quite interesting. When we saw her the next morning, the potassium has not budged. He was still having a potassium of 7.2 despite being on dialysis for around 12 hours. Patient was still acidotic. And clearly the thoughts were like, this is one of those patients who probably has required higher CRRT dose. So the treating physician actually increased the dialysis dose and increased the total effluent dose to around 45 mils per kg per hour. Now, to achieve that on the citrate dialysis, one would have to increase the citrate dose as well. The citrate dose was increased. This prescription was continued for around next 4 hours, and the outcome was very similar. There was some improvement in the acidosis, but still, like patient was still showing some signs of significant hyperkalemia. The next thing which we did was to change him to Hemosol, and we further increased his dialysis dose. And in next 3 to 4 hours, we managed to get on top of his electrolyte disturbances and hyperkalemia. So this is what I mean is what you want to achieve from your dialysis. You need to have clear goals, and you need to direct your treatment based upon the targets which you want to achieve from your dialysis. So this is probably my last slide, and the thing I would like to convey by bringing precision into your renal replacement therapy. Whenever you think about renal replacement treatments, always think about what is the optimal time, what are the risks and advantages of exposing your patients to renal replacement therapy. Always think about the solute clearance and what is the desired solute you want to remove from your renal replacement therapy. Always think about adjusting the hemofiltration component, the dialysate component, thinking about the filter life, monitoring patients' citrate load, citrate toxicity, and do not forget about unintended losses of the important other solutes, such as the vitamins, such as the other nutrients, which we rarely monitor, and adjusting the antibiotics and other medication doses when patients are on CRRT, and especially when on high dose CRRTs. Thank you. I'm open for questions.
Yeah, so thank you, Dr. Harshel, for this elaborative and very, I would say, the recent innovative thing that can happen in maybe next 5 to 10 years would be having very much precision in everything related to AKI as well as also the management related to AKI. Also, I would be also taking one question here in the chat box. Does higher effluent dose on CRRT help in decompensated CLD patient?
So again, like the decompensated chronic liver disease patient, I would say, what would you like to achieve from the dialysis is my question. If the indication for these patients to go on the dialysis is in the form of acute kidney injury, and that is again from some reversible causes, one thing, then yes, they can go on dialysis and achieve, try and have it. But if one thinks that the kidney injury in these scenarios are mainly from, say, hepatorenal syndromes, one should be very careful that whether offering such sort of dialysis in patients with chronic decompensated liver disease is appropriate or not appropriate. The second scenario I would say is patients who've got hyperacute liver injury and say, for example, from mushroom poisoning or from paracetamol poisoning. Absolutely, those patients who've got significantly higher ammonia levels, those patients, I think the CRRT is a must, and those patients should be given appropriate doses of CRRT for ammonia chopping. With regards to the ammonia trapping, again, ammonia is freely filterable across the membranes, so there is no need for higher doses of CRRT dose to have ammonia clearance. They should be just okay to have normal sort of dialysate and hemofiltration component in their dialysis dose. I hope I've answered the question.
Yeah. I think the answer is very clear that we need to like individualize the patient and also take care of many things at a like a large rather than only pointing towards a single thing. Yeah. So thank you, Dr. Harshel, for your time. And I think it's late night.